Hi, this is Dr. Kapoor, and I'm going to talk about general evaluation in renal disease. Very commonly, renal problems in patients are presented in an asymptomatic fashion. A variety of non-specific complaints are often encountered in patients with renal diseases. In many patients, there is worsening hypertension, edema, and malaise. There is a great deal of importance attached to investigations, and these investigations help identify the etiology and differentiate between acute and chronic issues. Serum creatinine, blood urea nitrogen, electrolytes, and urinalysis are extremely important aspects of evaluation of renal patients. Although creatinine reflects GFR status, please keep in mind situations where it can lead to overestimation of GFR. Of great value in glomerular disease have been estimation of antibodies, complement levels, ASO titers, viral serologies, especially hepatitis B, hepatitis C, and HIV. Protein electrophoresis is helpful in gammopathies. Let's talk about urinalysis. First, we'll discuss about proteinuria. Proteinuria is usually discovered on urinalysis, especially routine urinalysis. Protein excretion varies from very small to very large amounts. Tamm-Horsfall proteins are secreted by tubules in very small amounts. Diseases related to tubules often are associated with substantial amount of protein excretion, with very large amounts of protein excretion are undoubtedly associated with glomerular diseases. It is important to determine how much protein is excreted in 24 hours. One can choose to go for protein to creatinine estimation or 24-hour urine collection. This again depends on the stability of creatinine levels in patients. A normal protein to creatinine ratio is less than 250 mg of protein per gram of creatinine. Accuracy-wise, 24-hour urine collection can have its own disadvantages. It often leads to underestimation or overestimation of protein excretion, depending on the method of collection of urine. Microalbuminuria is a term used for presence of very small amounts, 30 to 300 milligrams of urine protein. Understanding of microalbuminuria is extremely important in diabetic patients. This can lead to deteriorating renal function in this population unmistreated. ACE inhibitor therapy is helpful in diabetic microalbuminuria. Albumin is detected by dipstick, but unfortunately, light chains such as Bence-Jones proteins in multiple myeloma are not detected by urine dipstick. It is important to identify and treat underlying diseases in patients with proteinuria. A proper history taking and investigating procedure should be adopted. Some of the diseases which are responsible for glomerular proteinuria include membranoproliferative glomerulonephritis, membranous nephropathy, minimal change disease, focal segmental glomerulosclerosis, diabetes mellitus, HIV-associated nephropathy, SLE, and medications such as lithium, gold, and penicillamine. Tubular proteinuria is associated with NSAIDs and heavy metals such as mercury and lead. Overflow proteinuria is associated with multiple myeloma, light chain deposition disease, amyloidosis, myoglobinuria, and hemoglobinuria. Tubulointerstitial diseases are caused by some infections, analgesics, and myeloma kidney obstruction. Fever and exercise are also some of the causes that cause proteinuria. We will continue our lecture